again. This is our health and science focus here on Today. Now, our focus shining the light on autoimmune diseases today. This is a condition where the immune system attacks healthy cells in the body. Now, experts say there are many types of autoimmune diseases. Some include diabetes, arthritis, and lupus. There are over 80 that we know of. Now, rheumatoid arthritis is particularly prevalent among women, as we know. Now, rheumatologist Dr. Debbie Haasbroek here to discuss this with us. Doctor, very good morning, and thanks for your time this morning. So you are a rheumatologist, so you deal particularly with conditions like rheumatoid arthritis and lupus, which is another rheumatoid condition. Let's start with rheumatoid arthritis. What is it?
So rheumatoid arthritis is an immune-mediated condition where the body forms antibodies and, generally speaking, attacks mostly the joints, and you present with an inflammatory arthritis. That's the hallmark that's common to most patients, which is why they get referred to us. However, it's a multi-system disease, so it also can affect the eye, the lungs, the heart, and in long-standing cases, even the kidney.
Wow, okay, yeah. This is something I imagined only attacked your joints, so it only attacked, sort of fingers and gave you that kind of condition. So
no,
it's much worse
so that's the one thing with autoimmune diseases. I want to say that's the common thread amongst them all, is they present with an inflammatory arthritis. So anything from rheumatoid arthritis to lupus to some of the rarer conditions like Sjogren's, etc., they can present with an inflammatory arthritis. However, all of them are multi-system, which is why it's important that you get to see a rheumatologist that we can check for involvement in the other organ systems.
Okay, because I was wondering about my pinky finger here, and I've had this little bump on it for years now, and it can't straighten. So that commonly with my Hashimoto's would be accompanied by something like that.
Yeah, so when someone like you would come and see us, we would check and see, do baseline blood investigations, x-rays, etc., and we would check and see. The commonest thing for the distal involvement of the finger is what we call nodal osteoarthritis. Yes. And then if it's involving, for example, your MCP joint, the metacarpal phalangeal joint, or the wrist, for example, that's more common in rheumatoid arthritis. So we check at the pattern distribution of the arthritis and also specific changes on x-rays.
Okay, so lupus. Give us the lowdown on lupus now.
So lupus is definitely more common in women. Basically, from what we know, there's a genetic predisposition. And then there's a second hit or environmental triggers. So in lupus specifically, estrogen plays a very big role, which is why it's more common in women. And then UV light from the sun can also trigger a lupus flare. And then basically the combination of those two factors results in disease progression. Yeah.
Okay, I recently learned something very interesting, and just to steer a little bit away, is it common that somebody with breast cancer might develop lupus, or lupus, that person might develop breast cancer? Because I know of two people who had both. Is there a link?
So it's a complicated question. So basically what happens, first of all, you get something that we call paraneoplastic phenomenon. So sometimes a malignancy, so for example like a breast cancer, before the patient gets diagnosed with it, they can present with a rheumatological condition. Anything from like a proximal myopathy that we get with dermatomyositis, or an inflammatory arthritis looking like a rheumatoid arthritis. And then on further investigation, then we actually see it's the actual underlying malignancy that's mimicking the autoimmune condition. So that's the one problem. And then from the other side, patients that have been on chemotherapy can develop also immune conditions that mimic rheumatoid, lupus, etc., as a result of a drug-induced immune condition.
Okay.
Do you see what I'm
saying? So that would be the link. All right. So how would I know? How would somebody know? You sort of gave us a bit of an example when it comes to what you might see. With rheumatoid arthritis, what are the symptoms? What are the things we should be looking out for?
So the big thing that we look out for is patients must have a chronic inflammatory arthritis. And when we say chronic, we say anything beyond 6 weeks. And the things that you can look for: early morning stiffness, for example, more than 30 minutes. And when I say that, it's like literally that the patients have difficulty closing their hands, opening doors, etc.
Would the ankles also be? Because when I get up in the morning, sometimes I'm quite stiff.
Most commonly for rheumatoid, if your hands aren't affected, then we question the diagnosis. But yes, it can also be the soles of the feet, the ankles, etc. So pattern distribution is very important. And then basically that they have to take anti-inflammatories daily, etc., and that there's no resolution. So even with the anti-inflammatories, the pain's worse in the morning and can progress all the way up until like midday, etc. Some patients have pain and stiffness into the day. And then, like I say, we look at pattern distribution of the joint. And then we do blood tests. And some of our patients are what we call seropositive rheumatoid arthritis. In other words, they're rheumatoid factor positive or ACCP positive. We also get a condition called seronegative rheumatoid arthritis, but that's why we look at the company that it keeps, like again, pattern of joint involvement, etc., chronicity, etc.
And lupus symptoms?
Lupus, sure, that's very difficult to answer very quickly, but the general thing with lupus is, again, arthritis. They can get a typical malar rash, which is this red butterfly rash on the cheek. They can also get scarring alopecia or hair loss. That scars in the area where the hair falls out, and then other things. So, for example, in lupus, there's a very big component where it affects the central nervous system. So they can present with refractory depression, psychosis, etc., to anything like a stroke, peripheral neuropathy, etc. So it's quite a broad spectrum of involvement. It involves the nervous system in 19 different parameters. And then anything from lung involvement with interstitial lung disease, pneumonitis, etc. And then also our group of lupus patients are also at risk to get something called Antiphospholipid Syndrome, which presents with recurrent miscarriages, recurrent deep vein thrombosis, pulmonary emboli. So it's quite a broad spectrum of presentation.
Are these common in South Africa? Rheumatoid arthritis and, and lupus?
It's one of the commoner autoimmune diseases, but obviously in terms of in our population, less than say 5% of the population do present with lupus or rheumatoid arthritis. And then just also as a point, some patients can be ANA positive, but it doesn't necessarily mean that they have an autoimmune condition.
They're just carriers.
Yes, you're just a carrier of the antibody and you never develop any symptoms. And that occurs in about 10 to 15% of our population.
Are they race specific, Doc? And I know it might be a touchy question for some people to, to digest, but because I know some people say, yes, it's mostly Indian folk or it's mostly African people who suffer from certain things or white patients. So are they race-specific?
Yes, definitely. Well? So, for example, in terms of, I'm going to say all my rheumatological conditions, so the seronegative spondyloarthritis or ankylosing spondylitis, more common in our white patients, okay? Especially those from the UK, the Scandinavian area, etc., if you trace their ancestry back. In terms of lupus, definitely more common and more severe in our black patients and Hispanic patients. And then the rheumatoid arthritis, definitely we see across all races, but autoimmune conditions, generally speaking, the Indian population are at a higher risk to develop them, as well as other conditions like psoriatic arthritis, etc. So each race has their Achilles heel.
Very interesting. So treatments for these, very quickly for us. Rheumatoid arthritis, let's start there very quickly. Treatment, I would imagine, I don't know, would it be also dietary changes, things you should avoid, keeping busy, keeping fit as well?
So definitely we obviously have our disease-specific treatment or medical management, and then added lifestyle changes. So in terms of the hallmark of treatment is obviously what we call disease-modifying anti-rheumatic drugs. So that's like methotrexate, plasmoquin, cilazopyrin. Those are the commonest drugs that we use. And then in conjunction with low-dose prednisone and anti-inflammatories or other analgesics,
a lot,
depending on the patient. And then definitely lifestyle modifications. So we do advise our patients to follow an anti-inflammatory diet, avoid inflammatory triggers. So, for example, gluten and things like that, dairy, etc., can be
even certain
pro-inflammatory.
vegetables and things that all are good for you.
And then the big thing from rheumatoid arthritis is smoking is the biggest environmental trigger that actually causes citrullination of the proteins. And our rheumatoid patients that smoke have more severe extra-articular disease, and it's also more difficult for us to get them in remission. So that's the biggest thing they can do, is to stop smoking.
And then lupus treatments?
Lupus treatment, very similar to your rheumatoid arthritis treatment. Also that like baseline of disease-modifying drugs, like I mentioned before. And then sometimes for the lupus treatment, because they have more severe involvement, so if there's brain or kidney involvement, then we do what we call chemotherapy, which is intravenous cyclophosphamide, which is a potent immunosuppressant and helps control disease progression in those important organs.
Okay, so that's a lot to digest at the moment, but hopefully we've given somebody a clue if they're not feeling quite themselves, and a lot of these fit the bill in terms of symptoms and what they're feeling. Thanks very much, Dr. Debbie Haasbroek. We'll let you get back to your patients this morning. And yeah, that's where we are. That little bit of a focus there on rheumatoid arthritis and lupus, common as we know, especially rheumatoid arthritis there among women. Well, we are going to talk about the psychology of this all. We heard the doctors tell us that your stress levels, your lifestyle changes as well, all of those things make a big difference to how you live with these conditions. We'll also focus on nutrition as well before 10 o'clock this morning.